Welcome, everybody, to another Wednesday VMR. I'm so excited to be here, Sharmin here, and I am very lucky to get to discuss a case with the one and only Ethan. Hey, Ethan.
Hey, Sharmin. Very happy to co-discuss with you. I remember the first time I encountered clinical problem solver is listening to a podcast that you and I think I forget the other co-discussant discussing a case on the podcast. So it's kind of like a dream come true for me. Thanks for the opportunity.
Oh, well, thank you for sticking around after listening to me discuss. I appreciate that, Ethan, that I didn't ruin CP solvers for you. But I'm such a big fan of you, and I'm super excited. Big shout out to Bayan and Rahul for doing scribing and teaching point. And we have an awesome case presenter today. Baha, do you want to say hi to everyone and introduce yourself?
Hi everyone. Name's Baha. It's my third time presenting a case. I am a junior doctor here in Morocco, and I'm pursuing the PLAB pathway. And yeah, it's always a pleasure to be here.
Thank you, Baha. Morocco is on my list of places that I really want to travel.
Oh,
So I need to hit you up for Rex at some point.
sure, sure. I'll be
Uh,
your guide.
oh, wow. Very, very lucky human. Thank you so much, Baha. All right, if we can get the board up, we can get started. Baha, whenever you're ready.
Sure. So today we have a 60-year-old female who presents to the hospital with severe respiratory distress. Oxygen saturation is 75%. Respiratory rate is 40, and she had skin marbling. And I will stop here.
Wow, I just immediately became tachycardic. I don't know what about you, Ethan. What are your thoughts on the chief complaint?
Yeah. So I really like the dyspnea pyramid. Sounds I think it is a kind of a OG schema in the clinical problem solvers. So we look for cardiopulmonary systems, look for cardiopulmonary causes in dyspnea first, and then goes up from there. But in here we also got the saturation, which we can translate into hypoxemias. And I really like to go back to the basic oxygenation formulas, which consists of the hemoglobins and the PaO2, which combines of the oxygen content. So here, I think the fact that the patient is hypoxemic means I think there's either like a cardiac output problems, or there's a lung problem that interferes with the interface of the oxygen exchanging membranes. And then I think also the Baha give us the respiratory rate of 40, which is signify the severity. So definitely want to manage the patients first, stabilize the patients first. Give in this patient definitely want to give I will give high level oxygen first, and then if not responding well, then definitely want to consider intubation first. And then as we see that the patient also has skin marblings, we definitely want to characterize first. But right now, I think kind of reminds me of the libido reticularis. So really, I'm worried about already cardiopulmonary decompromise in this patient. So yeah, really worried about the patient right now.
Oh, beautifully said, Ethan. Yeah, I'm really worried about this patient as well. So we have someone who's coming in with acute hypoxemic respiratory failure, starting in the 75s with this skin marbling. You know, I don't know if I can make much progress in skin marbling. I'm like, oh, is this just like, is she more like cyanotic? Is that kind of effect of the decreased O2 saturation? And then I think that in time would reveal itself. So my focus would be just completely on the hypoxemic respiratory failure for now, similar to you. And for me, if I'm like, seeing this patient right off the bat, as you mentioned, is all about stabilization, stabilization, stabilization. And so putting it like from the get-go, like figuring out what her mental status is. If she can maintain her mental status and her mental status is okay, then I think something like high flow nasal cannula or like a BiPAP, if like she's like crackly or like has a history of like COPD, asthma might be helpful. But I think if she has like some mental status, one of the first questions I would ask is she is like an intubation within her goals of care, because I worry that this is a patient that we might have to intubate fairly quickly, and you just always want to make sure that you have the code status of the patient right correctly. In terms of the hypoxemic respiratory failure, the couple of things that, is like getting the other vital signs. If the patient is like hypotensive and hypoxemic, the one thing that you definitely don't want to miss is like a tension pneumothorax, because like treatment of that would be very different. And you definitely don't want to give them anything with like positive pressure if they have like a tension pneumothorax. So that was like making sure that you listen, get the vitals, listen to the lungs, and kind of like say what the lungs make. Are we dealing with a primary pulmonary process? Like if there is a decreased breath out on one side, getting the chest X-ray fast. If they're like crackly, rhonchi, then you have to like support the oxygenation. And in terms of the acute hypoxemic, I think for the most part, we're more likely going to be in like a gradient. So thinking about like what's going on with the airways, the parenchyma, effusions, or are we dealing with a vascular etiology? And then after that, like as you mentioned, like cardiac etiologies are a good thing to consider. There are like methemoglobinemia. If like put the oxygen on and patient is not correcting, then you have to like kind of invoke issues like methemoglobin, as you mentioned, like the biting issues that might not correct with hypoxemia. But those are kind of the first things I would like kind of pay attention to. First, you got to manage this patient, get the rest of the vital signs, take a quick listen, make sure you have the code status, and then give oxygen. And this is someone that you might need help fairly quickly in the ED. All right. We are off to a fiery start. Baha.
That was very insightful. I will just add that she had prolonged capillary fill-in, more than 5 seconds, and she had cold extremities. She has a history of COPD, and she's an active smoker. Pack year history, but it's not specified. In this case, it's significant given her severe presentation. I will add that her blood pressure was 160 to 96, but it dropped further to 80, 54, despite vasopressors, noradrenaline and dobutamine. And I will stop here again.
Yeah, so maybe I can go first. So basically the pictures of prolonged capillaries and cold extremities with the low blood pressure. So I think we're dealing a problem with a patient with basic shock. I think Baha already mentioned that the patient is not responding to pressors. So in shocks, we like to like categorize into obstructive, cardiogenic, and distributive. And with the cold extremities, we're really focusing on the obstructive or the cardiogenics. And really, I think two hypotheses could be possible, but I think the fairly question I think we can think about is that we really need to identify the things that we could like immediately like deal with, like the intention pneumothorax, the cardiac tamponades. We can do that. We can see that fairly quickly with a POCUS. And then, yeah, really just want to get an EKG really quick and get the troponins. Yeah, and other than that, I think the past medical histories of COPD is interesting as well. I think because COPD, I think patient is also a high risk of pneumothorax because of the emphysemas. Also, because in severe COPD, we can have like right heart failures, I think, due to core pulmonales. But I think the time course being relatively acute here is, I think we need to focus on, I think the acute obstructive causes, and then the acute myocardial issues. Yeah. Also, I think another one is that we could miss is a PE, and maybe I think I don't think I want to see the heart rate to see if there's a rapid hyperacute heart failure is caused by tachyarrhythmia as well. So I think the EKGs and the focus is really key here. Yeah.
Yeah, absolutely. This is very sick patient, and I really loved how you centered it around shock. That's how I would frame this patient, and like kind of running through the different buckets. Yeah, I totally agree that, there are signs that points to like maybe cardiogenic obstructive pathology with like kind of like the cold extremities. And I mean, the fact that they started on dobutamine, they might have had high suspicion for that. She doesn't have any history of like heart failure. I think the rest of the exam here would be helpful. Like if she has like any evidence of volume overload, looking for the JVP, what is lungs are. Do you hear a lot of crackles? Are you worried about a pulmonary edema? Then I think I think like with people when you are in an intense situation, like someone who's on two pressors, still hypotensive, then every clue you can get from the patient would be really, really helpful. So far, I'm not 100% sure which bucket she fits in. You're right that, attention pneumo can cause someone to be hypotensive, and she has prior history of like obstructive lung disease. I really love that connection that you made between those two. The other thing that I often think about, when I'm worried about cardiogenic shock is like kind of the pulse pressure tends to be narrow. When she first came in, she didn't really have a narrow pulse pressure. When people's blood pressure like drops to the 80s, it's a little hard to make much progress in terms of the narrow pulse pressure. And the other things to kind of think about, as you mentioned, like tamponade physiology, a lot of the times, when you're in this situation, you're like, do I give a fluid or not? Most often, small boluses or like, raising patient's leg or doing Trendelenburg is like you are effectively giving people a little bit of a 300 cc's, and you can see what it does to their hemodynamics. But I think like before even doing that, in reality, you would like have the rest of the exam and to help guide you a little bit more about like what you want it to do. So yeah, the three buckets that were oftentimes that worry about is like, kind of obstructive, cardiogenic, distributive, hemorrhagic. The other thing to note about like, uh, low hemoglobin doesn't cause usually hypoxemia. As, you mentioned the dyspnea pyramid, it doesn't cause dyspnea, but if she has two pathologies going in with like a decreased cap refill, you just always like want to make sure you give a thought to like a hemorrhagic, probably less likely. Distributive, are we dealing with like kind of septic pathology with like foci of the infection center of gravity being the lung? Possibly. The cold extremity argues a little against that because they tend to be more distributive and warm to touch. Obstructive is a really good thought. I like thinking about tamponade and PE, as you mentioned. And I kind of like put tension in that similar bucket. And then like cardiogenic. The other thing that I would add, if someone I don't have that much like history or can gather history, and they have like a very fast pressor requirements, you always are going to get an ABG just to make sure what their pH is. Some of your pressors don't work as well when the pH is really low. Vasopressin is your friend. That's the one that when the pH is low, it also tends to still work effectively. The other thing to always like get as well, and and the other thing that I always like that I think about is like just throwing IV thiamine, especially in someone who you don't know much data, like very, very oftentimes like people are very vasoplegic, and that one they and the thing that they need a lot is thiamine. And this is the person that you just do get all the labs and like cultures and everything else, because like you just have to move urgently. Any other thoughts, Ethan? It's such a rich case.
I know, I think you're the basic poetry. I can listen to you all day. Yeah, excited for. I think no, a focused physical exam is really key here. As like if there's JVD, then you can really like look for like maybe tamponade or a right heart failure etiologies. And if there's no breathing sound, then you could quickly identify as a pneumothorax. Yeah, I think the fact that you focus on the physical exam, I think is really, really important here. Yeah.
Yeah, all right, back to you, Baha.
Awesome. Um, I will go to the physical exam and the vitals. So her heart rate was at 195. Her respiratory rate was 40. Her oxygen saturation was 75 on room air, and it improved to 92 with 15 oxygen. I will go to cardiac exam. Heart sounds were muffled, no murmurs documented, and no GVD was recorded. Pulmonary exam, bilateral crackles with diminished heart sounds. And the neurological exam pre-intubation, she was slightly agitated. Her GCS was 10. Her pupils are reactive and symmetric, no focal deficits. And the post-intubation, she was sedated, propofol and midazolam, but she later awoke with normal GCS. Her extremities were cool and mottled, and I will stop here.
Yeah, great exams. And then I think the first thing is that the heart rate of 195. I think Robbie always told us that in a tachycardia, you have to like know that if it's a autonomic, like maybe say atrial fibrillations or a flutter, so um, a a rate that just because it pumps itself, or it's a reactive, so sinus tachycardia. And so basically the patient has hypotension, so you expect tachycardia, but you still want to get an EKG to see the rhythms. And then other things notable on physical exam is the muffled heart sounds, which we usually associate it with we maybe suspect there's some kind of tamponade or something there's something between our stethoscopes and the heart, so makes the heart sound being muffled. And the bilateral crickles is kind of expected because of the COPD, but it still could be a manifestations of a pulmonary edema. So we probably need to clarify that further. And then I think the other thing is probably pretty expected. And then the decisions of, I think, 92% on 50 liters. So I think the decisions of intubate this person early is really cool. It's really good. I think the pearl that like my seniors always told me is that if you worry about the patients, if you are thinking about if the patient need to intubate or not, and that's the time you should intubate the person. Yeah.
Yeah, I love that. That is such a great pearl. It's kind of like how I always, that's my rule for pulmonary embolism as well. If I'm like really thinking back and forth about like, should I get the CTP? Should I not? I'm just like, I could just get the CT value for the pulmonary embolism. I really love that pearl. And yeah, I think like now we're forming a picture of like, we're worried about like either obstructive or cardiogenic with bilateral like crackles. It sounds like she has some component of volume overload. And, I think in reality, like muffled heart sounds are hard to make too much progress into like people's morbidity habitus, as you mentioned, and as well as like, the COPD, which is a great thought, can cause like the muffled sounds. However, I think in this patient, you just have to think about tamponade obstructive physiology. And the reason to think about that is that it's an extremely a preload dependent state, you often like see like people very tachycardic, and also when you're intubating people with that are preload dependent, like it's just dangerous. Kind of like also people with right-sided heart failure. You see anesthesiologists very nervous about these patients because like if you drop their preload any further, they can't code. So that's something else to be aware of when you're trying to intubate a patient like this. And I think this is someone that like if you have access to a bedside echo or at least like do the pulses would be really helpful to see if this is someone that if you don't have access to the bedside echo, do the pulses to see if you're dealing with like a tamponade physiology. And then, the bilateral sounds, we talk and we entertain tension for a while, but like, the bilateral sounds probably less likely, still get the chest X-ray to confirm. And the other thing to always like kind of think about in this obstructive pathology that I don't think this patient is like abdominal compartment syndrome. Oftentimes I can present with like an obstructive shock pathology. Again, less likely this patients. And the other ones that I often like have to remind myself are like the alpha tract obstructions, like Hokum, Takasubu, that oftentimes can have similar manifestation. So for this patient, I think like if it's probably like getting the setup lab, getting the chest X-ray, and also as you mentioned, like the ECG, I would not. I mean. Some 60-year-olds going in the 190s is very impressive. I would not bring down that heart rate at all because most likely my suspicion is that is compensatory to the fact that probably this patient's stroke volume is down. So the heart rate needs to compensate to be able to have as much cardiac output as possible. But like, and I think like getting the ECG, getting your cardiac markers would be really helpful. And I would still like get that ABG too to see what her pH is doing. This is like less likely to be like, the COPD. So I'm not as much worried about hypercarbia, but it would be good to know if you're dealing with a hypoxemic hypercarbic or just hypoxemic respiratory failure in this case. So yeah, any other thoughts, Ethan?
Yeah, I think the thing that I noticed is that usually if we're suspecting about tamponade physiology, but there's no JVD though. So I think that's a kind of a interesting findings. Well, I think maybe early tamponade, the pericardial hypertension maybe it's not that severe to cause JVDs, but I wonder on how that would change your pretest probabilities of right heart failures or a tamponade physiologist. Yeah.
That is a great question. And I think like, with any physical exam finding, your pretest probability of how it changes is about how good you are at that exam, right? If I was evaluating this patient at the bedside and I couldn't see it, couple of things. Sometimes we miss it because we just stare at the lower neck, start at the ear. And sometimes in patients who JVP is very elevated, it's right very high up. So oftentimes we miss it because we're not looking at the right place. So what I've learned from like when I was a resident working with cardiologists is that just start from right up top and go down to try to see JVP when you're like really worried about it. The other thing, yeah, you made a good point about early tamponade, but I just always like entertain a possibility of like, what if I'm just like not good enough at that? I'm not good at seeing it, and body habit is too. The other thing, if you have a bedside ultrasound, is really helpful, is to also like taking a look with ultrasound to make sure the JVP is actually not elevated. So in this case, I will just because just how life-threatening tamponade is, I would be just based on the exam and not seeing elevated JVP, I would be hesitant to drop it too far down and be reassured, if that makes sense, Ethan.
Yeah, that's amazing. Yeah.
All right, back to you, Baha.
Sure. That was a great tip on the heart rate, by the way. So I'll give you the ABG and the lactate. The lactate was 7. Her pH was 7.16. PO2 was 143, and the PCO2 was 43. I will pause here before I give you the more lab results.
Yeah, sure. So basically, we're dealing with a metabolic acidosis. This PCO2 is slightly elevated, but kind of in acidosis we expect the CO2 to be down, but the patient also has COPD, so I think kind of explain the compensations, but the fact that the CO2 is still high, a little bit higher than the normals. So I think the lactate is elevated, which is expected because of the systemic hypoperfusions. So I think the next step I would like to is to like clarify the acid-base disorder by getting the electrolytes to see if there's an ion gap, or usually because of the elevated lactate, we should expect an elevated anion gap. But if not, we could also search for another component of non-anion gap acidosis. Yeah, I think this ABG right now fits the clinical pictures. Yeah.
Uh, yeah, I totally agree. You know, she has lactate of 7, very elevated. So I suspect she has some degree of anionic metabolic acidosis that is related to that. But when was this ABG done? Was it when she came in, or is she intubated at this time?
Yeah, after she was intubated.
Okay. Do you know, was she like 100% FiO2, just out of curiosity?
No, because this is not actually a case I attended to.
Oh, okay, okay, got it.
Yeah.
No worries, no worries. Yeah, so no worries. This is awesome. So yeah, I oftentimes like, you know, I think getting an ABG, thinking about the context of the patient, like one thing that would be helpful would be like kind of their WEN settings. If this someone is like, you know, on 100% FiO2 with this pH, that PaO2 is like 143. Is that kind of where you would expect? Correct me. Um, I haven't managed an ICU patient in a while now. Correct me if I'm wrong. So I agree that I think she still has probably a component of AA gradient, but that's something you can calculate once you have like the other parameters as well. I also like, you know, we know she has like crackles on exam. She has underlying COPD, so I'm not surprised by her hypercarbia. It's just well to something to keep track of. And I love that you were thinking about calculating. I always like get a little nervous about like, oh my gosh, what would the formulas for all the metabolic acidosis and all of that? But once you have the data, you can always calculate just to make sure you're not missing anything. But I think this tracks, right? This is someone that is coming in with a shock physiology that lactate maps onto it. And I think the tough time becomes like once if the lactate doesn't clear, then we have to think a little bit harder if something else is contributing to that elevated lactate rather other than like kind of the shock physiology right now. All right, now back to you.
All right. Unfortunately, I don't have the electrolytes, so I'll just give you the. So the troponin was 800, which is very high. Her BNP was 20K 600, also high. CRP was 38. Glucose was 20.7. Creatine was high, and there was no leukocytosis. Also, upon presentation, there was widespread ST elevations, but they were initially overlooked because she had primarily presented with respiratory symptoms. I will stop here again before I can give you more elaborate.
Yeah, sure. I think that's amazing. So an elevated troponin, so troponin elevation basically means myocardial injuries. And I like to think about the types of myocardial infarction. So type 1, usually the most common cause we see, which is coronary artery disease by acute plaque ruptures. But we also have to keep in mind there's type 2 MI. So in a patient with like this, basically in shock, it's very likely to have supply-demand problems to the heart. So you really want to trend the troponins to see the patterns, like how it fits to see if it fits ACS or not. And the BMP here, I think just means that there's fluids overload and the ventricle is basically distended. Yeah. So I think the fact that EKG is really key here is to see that diffuse diffuse ST elevation. So I think we could go into two directions here. Usually ACS, there's focal ST elevations, but I think if there's like a big artery, like a main LM stenosis, you could also still have a like a diffuse ST elevations. But another possibility is a perimyocarditis, I think. So causing the diffuse ST elevation, the patterns also could explain the troponins elevations. So probably I would, if it's in real life, I would look for definitely let cardiology on board and then look for other signs of pericarditis like PR depressions. Also looks for if there's any reciprocal change that could explain a ACS. And then I think getting that POCUS really quick to see if there's pericardial effusions which we can deal with quickly. Yeah.
Oh, beautiful, Ethan. Absolutely brilliant. I love how you were thinking through the elevated troponin and how that informs your management. And yeah, and I think the question is like, is the heart rate, that elevated troponin is a response to something else, or is it the driver, right? I think that's the two things we're debating. So I think the schema that I would like evoke at this time is like, okay, we think this patient is an acute, like kind of hyperacute heart failure, right? And that is causing most likely a cardiogenic shock. And just to kind of like, or just to kind of summarize what you were telling us is that are we worried about like an endocardium pathology and myocardium pathology or a pericardium pathology or rhythm? Again, like rhythm we think like is most likely just a compensatory response. So when it comes to kind of like endocardium, like the pericardium is a tamponade, right? We still need that echo and the pulses just to make sure this patient is on tamponade. The endocardium is like a lot of the times I think about the valves, right? Like acute valvular valve failures like aortic regurg, acute mitral regurg, and tricuspid regurg is kind of a little less likely to do that. And oftentimes, like if we say like, hey, I actually worried about this patient had an MI. If it accompanies by a chordae rupture, oftentimes you can get like a hyperacute heart failure as well. Or is it like a myocardium issues like something like, a giant cell myocarditis, eosinophilic lymphocytic myocarditis, these myopericarditis, these things have a component of hyperacute heart failure to them. And then we also, like how you mentioned ACS, with this diffuse ST segment elevations, are we dealing with like a really severe case of ACS that is causing a decreased contractility or leading to complications like a valvular rupture, for example? I still like keep thiamine very high on my differential. So I just like put on IV thiamine in a patient like this because beriberi can more certainly cause a hyperacute heart failure. And in a patient, if this was like a younger patient postpartum, like peripartum, a heart failure can also be one of the etiologies. And some endocrinopathies can also do it. But for this patient, I think like what you mentioned about trending the troponin and getting cardiology involved sooner than later would be helpful. I would say if you have, um, if like, hemoglobin is fine, nobody will fault you if you start like a heparin drip in someone just to make sure we're not dealing with like a massive MI. But I think like if you can get a bedside echo or like an echocardiogram as soon as possible, that's going to really help push this case forward. Do the pulses and trend the troponin and trend the ECG and see, especially now that it's anticipated what is happening to this heart rate, how much pressure requirements does this patient have would be really helpful. Any other thoughts, Ethan?
Yeah, great thoughts. I really love the part that you mentioned about the complications of ACS, like a papillary muscle ruptures. Yeah, so I think a reason for I also learned that is also look for the like subtle clues in the EKGs, because like the complications of ACS like happens in timelines. So like papillary muscle ruptures usually happens in like a three to 7 days. So if you see like a Q waves in EKG, which could mean there's a underlying maybe a more subacute process, which could lead to a presentation like this. So I think in real life, I think we would get the EKG first. So I think like look for these subtle clues is really key, as you mentioned. Like also think about systemically through the endocardians, like endocarditis, although this patient probably does not fit, or like myocarditis and ACS of the myocardial problems, and then pericardium of the tamponade issues as well. I think that's a really great like approach to acute heart problem, acute heart failure. Yeah.
Love it. All right, back to you, Bahar.
Just want to mention that Lucas Vonrath, sorry if I'm butchering your name, he had mentioned something about the temperature, which is good to know in this context. So I will just add that she was afebrile, and then I will just give you so the chest X-ray. It shows pulmonary edema with bilateral effusions. CT angiothorax shows no pulmonary embolism and bilateral pleural effusions. And echocardiogram shows an FEVG of 23%, so LV dysfunction with an apical thrombus and global hypokinesia. Then the last test is the coronary angiography, which I will tell you after just you discuss these results.
Yeah, great results. So the combinations of pulmonary edemas and bilateral effusions really points to heart physiologies, because like in flash pulmonary edema, we would not expect a pleural effusions. And the fact that the patient also have hypokinesias, I think, yeah, the right now the two hypotheses is either a severe CAD causing ACS, or I think a Takotsubo cardiomyopathies, which if the patient's the angiography is patent, probably we could point to a Takotsubo's. So I recently also learned that actually the typical like apical hypokinesis and I forgot it's basal or apical hypokinesis, like causing the balloon shaped and heart shape in the echocardiogram is actually not like very specific. Like it's not always presents in Takotsubo cardiomyopathies. So essentially, you need a coronary angiographies to differentiate the two problems. Also, actually, I think we could look back to the EKG to see if there's clues to Takatsubos like QT prolongations or diffuse T-wave inversions and things like that. Also, I think the patients like a 60-year-old female kind of fits the populations of Takotsubo's. Also, I think another clue we could look at is the trend of troponins. Like Takotsubo, you get a high troponin, like persistent elevated troponins, but in ACS you get a peak and then it down and like trend down of the troponins. Yeah, but also the patient actually does not have any she does not have, at least we does not know she has any hypertensions or diabetes or smoking history. Oh, she is a smoker, but
Sorry to interrupt. Yeah, she has a
yeah,
smoking
yeah,
history.
she is a smoker, but not that much of um, a risk factors of coronary artery disease. But I think it could go either way. So um, really would need that coronary angiography to differentiate the two. Yeah.
Uh, Ethan, you're so great. This is absolutely very well said. Yeah, so just to kind of summarize, this is a 60-year-old woman with like kind of past history of like smoking, tobacco use, COPD, who's presenting with acute hypoxemic respiratory failure with most likely what we were worried about, the kind of hyperacute cardiogenic shock, secondary to this new diagnosis of heart failure, with like elevated cardiac biomarkers and diffuse ST segment elevations on ECGs. And I like, okay, we're not dealing with tamponades, so that's good. I totally agree with you if you want to like think about like both the elevated troponin with like the apical. Takotsubo is a good thought. Takotsubo oftentimes you don't see as a high of degree of like a troponin elevations. However, whenever you think about Takotsubo, you have to think about like ACS as well. They're great mimickers of each other, especially because like it mimics kind of like proximal LAD left main disease, especially in someone who has like maybe left dominant circulation. So this is someone that when you see these numbers, you should just treat for ACS, get the cath, and make sure the cath, the multivessel coronary artery disease, or like a proximal, like a left main disease or LAD, like if acute thrombosis is not explaining this one. And I think in that, then if the cath is negative, then Takotsubo is a good thought. Like Takotsubo is often induced by like stress, emotional, physical stress, and you want to make sure you also understand what the trigger might have been in this case. The other thing to also not lose sight of is like those like kind of myocarditis that we talked about, like that can cause like hyperacute, like giant cell, eosinophilic, those ones too. So I think like order of operation in a patient like that is like stabilize the hemodynamic as much as possible, give the left heart cath, and then make sure that if that is negative, does it really truly fit with like kind of a Takotsubo cardiomyopathy, or do we need to go looking for like some myocarditis pathology? And I think that, as you mentioned, the trend of troponin would be really helpful with myocarditis. They tend to like stay elevated. It might be go up and down, but it remains elevated, versus like for a STEMI, they tend to peak and calm down. So I think that would be really helpful. That I think, anything else from you? That's all I got, Ethan.
Yeah, 100%. I forgot to mention. Yeah, I think perimyocarditis is very much in play here.
Mhm.
But so if the angiography is negative, probably we could still like pursue an MRI to see if there's LDs. Yeah,
Yeah,
I think
yeah.
yeah, definitely.
I love cardiac MRIs. They're so helpful if they're available. If they're not, then it really has to be a discussion with the cardiologist whether they would do a biopsy. And with the issue with the biopsy is that it's like they tend to be like patchy diseases, and not at times like not again not it can be missed. So yeah, hopefully if not cardiac, if they have access to cardiac MRI. All right, Bahai, back to you.
So I will reveal the diagnosis here. The coronary angiography showed occlusion of the LAD, and it was treated with 2 DS stents after being sent for PCI. So the final diagnosis is this patient had cardiogenic shock that was driven by acute coronary syndrome, occlusion of the LAD, which was exacerbated by the underlying COPD. And that is it.
Yeah. Yeah.
Yeah,
Yeah, great case. Thank you, Baha, to like present a bread and butter case. I think these conditions are definitely the things that we will encounter in real life. And I think that this is actually a pretty amazing journey. Like we start with a acute hypoxemic respiratory failures, and then goes to a shock physiologies, and then going to like discussing about elevated troponins and diffuse ST elevations. So yeah, I think great journeys and great efforts by your team to go through this thorough evaluations. Yeah.
Oh, I love this case. I totally agree with Ethan. Thank you so much, Bahai. These cases are such great cases to remember and think about because you are tachycardic when you see a patient like this. So I'm like trying to remember kind of like this kind of muscle memories of the things that you want to do. I think one thing that is like really important to remember about this case, like that initial ECG that is gonna people are gonna get when she's going like 190s, you might not see enough pathology. So when the rate slows down a bit, repeat that ECG just to make sure you can like identify the underlying pathology. And an acute MI causing like a hyperacute heart failure. It's not very common presentation, but like one to remember and think about. Again, like I think with like hyperacute heart failures, think about the endocardium, the myocardium, the rhythm, and the pericardium, and like kind of systematically think about which one you're dealing with, bedside echoes, and like trend of ECG. And when in doubt, getting help, like ask cardiology first. And if you really have right, if there's no concern for bleeding, treating for ACS early, it's also going to be really helpful to stabilize that, especially when you think about LAD and left main disease. They can be pretty bad. Thank you so much, Ethan. You did such an amazing job discussing this case.
Yeah, thank you for co-discussing. I think that is a really like a top 3 CPS pro, like repeat the troponins, repeat the EKGs, repeat the UAs, like really repeat testing because the timing of testing is really just so important and really need to track these data to keep tracks of the clinical symptoms. Yeah, also thank you, Baha, again to present this bread and butter case, and we learned a lot from you.
I've learned a lot of you from you guys too. That was very insightful. And yeah.
Come back soon. Can't wait for another case. All right, Rahul, we're ready for you.
Thank you so much, Baha, for presenting this bread and butter case. And I really loved the Ethan's and Dr. Sharmin's discussion. And I really learned the nuances of repeating the EKGs, trending the drops. Now, coming back to the case, now we started with a significant desaturation with this significant respiratory distress. And Ethan brought up an dyspnea pyramid, thinking about any issues with the heart or issues with the lungs. Now we have this patient of dyspnea with the desaturation, where we have to, think about an alveolar capillary membrane where oxygen diffuses from the lungs into the circulation. Now, with a significant amount of distress with the desaturations and always stabilization first. So you have to go for A, B, C, D, E, and then managing his airway and oxygen. And we can go with high flow nasal cannula or BiPAP. And if the patient is having a significant hemodynamic issues with altered mental status, then definitely intubation would be the good choice. And given the skin marbling, and Ethan mentioned about present any evidence of livedo reticularis as well. But interestingly, now they have this patient of hypoxemia with the dyspnea with hypotension. Now it could suggest you of any intrathoracic hypertension like pneumothorax, pulmonary embolism, on any kind of obstructive physiology. In those things, we have to get a chest X-ray, and we have to limit the fluids, because not all hypotensions are distributed shocks or hypovolemic shocks. We just want to make sure whether it's central physiology or peripheral physiology of shock. And now, and Dr. Sharmin mentioned, when we're dealing with an hypoxemic respiratory failure, we can think about any alveolar issues, any vascular issues, or we have any kind of bilateral pleural effusions, which is compromising the oxygen. And now, interestingly, we have here prolonged capillary refill with not responding to double vasopressors, that really giving a clue of shock. It could be either cardiogenic, obstructive, and hypovolemic and distributed shock. But given, and also the COPD risk here, presence of COPD, there's also increased risk of pulmonary hypertension, thereby causing right heart failure. In all these scenarios, getting an EKGs, ABG, troponins, and pro-BNP would be really, really helpful. And now, if you look at the exam and the presenting history, it's just giving a flavor of cardiogenic shock. So you can look for any elevated JVP and crackles on the exam, and also narrow pulse pressure. And Dr. Sharmin really brought a very interesting point, which I've don't know before this VMR, that wet beriberi presents as a hyperacute heart failure, and you can prophylactically give thiamine in those patients as well. Now, coming back to the vitals, we have a significant tachycardia here, tachycardia 195. And it's important to tease out, is it sinus tachycardia, or else we are dealing with any kind of arrhythmias. But given the low stroke volume, we can really expect the amount of tachycardia. But given this hyperacute heart failure symptoms with the dyspnea, beta blockers or any medication that would lower the heart rate, it may not help the patient. And also presence of muffled heart sound, it can see in patient with obesity or COPD or cardiac tamponade. Now, as we thought, because the patient is desaturating and along with hypotension, and we are going with intubation. But if there is a presence of any pneumothorax, pulmonary embolism, or cardiac tamponade, which are really dependent on the preload, that really, if you're doing the intubation in those patients, really it's going to increases the intrathoracic pressure that would further compromise the vessels with the central vessels, thereby causing more decreased stroke volume. So in that scenario, just make sure you don't have it. Maybe you can get a bedside echo, look for RV strain, look for pericardial tamponade, and on the chest X-ray, you can look for pneumothorax as well. And given the lactic acidosis, where you can easily expect to the amount of low stroke volume here, it ranges from low perfusion as well. And given the acidosis on ABG, it really helps, measuring the anion gap and getting the electrolytes on board really help us. And also there's a given the high PaO2 of 143, and definitely you can look at the ventilator settings and how much is the FiO2 and how much is the PEEP, so that you can get some idea and what's going on with that patient. And in all VMRs, it's very trendy to look for UAs, trending the UAs, trending the troponins. And here, as Ethan pointed out, are we dealing with any type 1 plaque rupture MI, or else any kind of demand issue? And definitely training the troponins and repeating the EKGs would really, really help. And now we are sure that based on the exam, based on the HPI, we are somewhat sure about we are dealing with some kind of heart issue. Now, are we dealing with the outermost layer of the heart, which is pericardial issue, or myocardial issue, or any endocardial issue, or both myopericardial issue presenting as hyperacute heart failure? And also we have highly elevated pro-BNP here. Interestingly, at the atrial stretch, because of the volume overload, would result in high pro-BNP. If you are dealing with any kind of cardiac tamponade or pneumothorax, that would really present as sometimes as low pro-BNP, because there will be an atrial collapse instead of atrial stretch in those patients. Now on the exam, we have the pulmonary edema with bilateral pleural effusions that likely suggest of heart pathology, maybe like acute coronary syndrome or Takotsubo in this patient, and definitely angiography helps. And this patient has a classical picture of the MI. And interestingly, one differentiating feature would be there will be mildly elevated troponins in patient with Takotsubo cardiomyopathy, and diffuse wall motion abnormalities will be beyond the coronary distribution, but there is a significant elevation of troponins in acute MI, and the wall motion abnormalities will be limited to the coronary artery distribution. And if unfortunately, if angiogram comes negative, definitely you can get the coronary cardiac MRI. That will be gold standard to see what's going on with the heart valve, muscle, and pericardium. And the final diagnosis was cardiogenic shock secondary to the MI. And thank you so much, Baha, and thank you, Ethan and Dr. Sharmin, for the wonderful discussion.
That
Thank you.
was such a beautiful recap of the journey. Rahul, thank you so much. I don't know how you all do it so fast and so well. Amazing. Thanks all. See you next time. This was so much fun. Thanks again, everyone. See you tomorrow. Bye.